Thanks, Rod. Thanks very much for the invitation, and thanks for having us for the last couple of days. Stupidly put a time frame on this presentation for myself, thinking that I'd be able to keep to it, but I promise you that the only thing that is certain about this presentation that it'll be longer than 25 minutes, so I apologise in advance firstly, but hopefully I can hold your interest throughout, and hopefully there's some things of interest here. Look, as Rod's touched on, we're from a group almost exclusively made up of individuals with a background in exercise and sports science, some of us also with some expertise in strength conditioning as well. We have in recent times added a few individuals with some clinical expertise and background, and I'll present some of that work towards the end of the presentation today. But we started out 5 years ago with a group of three of us. It's Dr. Anthony Shield here, who's really the forefather of the group and the driver of almost everything that we do. And he was my PhD supervisor up at the Queensland University of Technology, in concert with Dr. Morgan Williams here, who was at ACU in Melbourne at the time and is now headed back home to South Wales. But in the space of 5 years, we've grown from that group of three now to, I think now in excess of 15 or 16 academics, researchers, clinicians and postgraduate students as well. So we're unique, I think, in a sense in that almost everyone that you see on the right-hand side here is got projects or multiple projects focusing specifically on hamstring strain injuries, hamstring function and hamstring structure. So we've somehow been able to manage to cajole that in an environment in Australia that's not necessarily geared towards sports medicine research. A couple of other guys that you can see up here, one who's actually here with us today, Ryan Simmons, who's done a lot of work in biceps femoris architecture, and I'll show a fair bit of his work today, and also Dr. Matt Bourne, who's just recently moved to La Trobe as well. Outside of that motley crew, there's a few others who have got work going on at the moment. A few I just want to draw attention to is Jack Hickey, and I'll speak a lot about his current randomised controlled trial looking at the early introduction of eccentric loading into rehabilitation, which I think will hopefully have some clinical implications for you guys today. And also this young fella here in the corner, Joel Presland, who's looked at the dose-response relationship between the Nordic hamstring exercise and whether there may be benefits to doing higher or low volumes exposures for those exercises. To just give you all a quick grounding into probably two of the methodologies that we've used most extensively and sort of pervades its way through the entire talk today, probably the thing we're most known for is something that is largely a simple piece of kit and development. It never really ever looked like this, but I've just always had this image in here. But essentially it was a block of wood, a bit of foam, and a couple of ankle hooks at the back there. And it was essentially a device to be able to perform the Nordic hamstring exercise without the need for partner assistance. And probably the one addition we made to that was that underneath those ankle hooks, we just placed these uniaxial load cells. And those load cells were able to transmit force then directly to a host computer. So by being able to take independent left and right leg measures during the performance of the Nordic hamstring exercise, as you see Tony there going through the full range of motion, they're pulling up on each individual strap independently. We're able to get some meaningful data within a short period of time. So within the space of 30 to 60 seconds, a typical testing protocol of 3 repetitions, you can see here we get force time data for the left and the right leg, and from that we get eccentric force data, and then also between limb imbalance or asymmetry as well. And for us it was important because it allowed us to be able to collect larger data sets, particularly in elite populations back home in Australia. They wouldn't come through to do isokinetic dynamometry. We didn't necessarily have the experience and exposure for handheld dynamometry, but we could take that device to the club. We could test a squad of athletes within 40 minutes, 45 minutes, and then we could use that data to collate some really large data sets. The other thing that Ryan's been working on a lot since his PhD and then after as well, and is largely the cause for our visit here for the next 3 or 4 days, is measures of biceps femoris muscle architecture. Now, this technique is not overly new, and certainly we're not the innovators here, but we've just focused specifically on biceps femoris. So if you can imagine that this image here is a little bit like taking our biceps femoris, cutting into it as if it were a steak, to look at it side on to see if it was cooked on the inside and if it was rare or medium rare or whatever it might be. That's the snapshot that we get here from 2-dimensional ultrasound. And from that we're able to pick out a few variables of interest: the extension of the tendon or the aponeurosis into the muscle belly, both intermediate and then superficial. From that, we can get an indication of the thickness of that muscle. And the streaky lines that you see running across the screen here are bunches of muscle fibres, muscle fascicles is what we can see on the ultrasound. By tracking those into the intermediate aponeurosis, we're able to get a pennation angle, and with a combination of all those variables, then we're able to get an estimate of biceps femoris fascicle length. And I think it's worth noting here that the vast majority of all the work that we do, and most people do, is to just get an estimate of that, because the field of view of most of the probes just aren't big enough to capture the fascicle in full sight. But we've done a lot of work around this measure, and metric in particular, and I'll present some of that data today. It's also worth noting that over the next couple of days, if anyone is interested in learning a little bit about this technique and this methodology, both myself, but more importantly Ryan, are here for the next couple of days. So between myself, Rod and Nickel, we'll be organising a few training sessions for anyone who might be interested in having a bit of a look and a bit of a poke and prod. Overall, our prevailing purpose for looking more at architecture was that we thought about strain injury in its true mechanical sense, in the ability to absorb and change in length, and presuming that if you're asking a muscle or multiple different muscles across individuals to lengthen the same extent, then surely a longer fascicle would be better able to absorb that change in length than would a shorter fascicle, and that's been the drive for a lot of our work. To give you some context as to where we come from a theoretical sort of underpinning, this is the injury that we spend most of our time focusing on, but in reality, the vast majority of those are biceps femoris long head injuries. So we don't necessarily think about hamstring strain injury necessarily, but we try to break it down into the individual components of the hamstring musculature, and with a particular emphasis on biceps femoris. As I've spoken about, these are our two major primary lines of research from the perspective of trying to identify individuals at risk. We're cognizant of the fact that there are a host of other factors, and that also this schematic is overly simplistic. These aren't single direction, univariate relationships of risk. This is obviously an oversimplification just to get the point across. But we acknowledge that there's a complex interaction of features going on here that I don't think if many of us know much about across sports injury generally. And I think hamstrings is an example where we have lots of really good data up here, but the interaction and interrelationship of all those variables is still largely unknown. Tying into that, we obviously have to understand the impact of exposure, both the positive and potential negative effects, and there's certainly more and more work coming out in that load monitoring space about how well periodised exposure to high-speed running can be really, really important. But I think this is just a relatively simple way to show a number of those variables that need to interact ultimately to put an athlete at high, moderate or low levels of risk. By and large, though, we spend a lot of our time flowing off the back of when injury occurs, and we know that that leads to subsequent rehabilitation, which I'll talk about later today. I won't speak much about imaging, but certainly the hospital here has done an amazing job looking at the impact or the usage of MRI and whether it's got any great value in prognostication for hamstring strain injury. For us, imaging really centres around some serial measures of architecture through rehabilitation. I can present some of that data later today as well. When we think about structuring our rehabilitation, as I'm sure everyone does who thinks about hamstring rehab, the two primary measures we're thinking about are return to play time and trying to make that as quick as possible, but then also minimising the risk of re-injury as well. And of course, re-injury risk will never be zero, but trying to mitigate that risk of re-injury as quickly as possible, whilst also returning in a timely fashion. But from our experiences, at least anyway, this can be done well or it can be done poorly, and we've seen a lot of examples of post-rehab, post-return to play, where individuals exhibit a phenomena of persistent neuromuscular inhibition. Now, the inhibition that we see is typically seen in the previously injured muscle and is often restricted to eccentric contraction modes as well. Now, inhibition in and of itself, you might necessarily think can pose a huge risk of injury recurrence. You might think of it as a protective mechanism. But the issue with inhibition is that we ultimately require high levels of activity and activation to be able to stimulate adaptation. And what we know is that those who are previously injured and have issues through rehabilitation and are left with inhibition often then find it very difficult to increase their levels of eccentric hamstring strength, and then by the same token to try and drive some favourable structural adaptations as well. And certainly from our perspective, we think that's a potential cycle that then can lead all the way through to the elevated risk of re-injury in those with a history of hamstring strain injury. Look, for the sake of today, I don't want to bore you with too much of the early stuff that we did around inhibition. Needless to say that I think there's a pretty good body of evidence now, not only from us but from others as well, that this is a characteristic, I think, of poor hamstring rehabilitation. It persists for long periods of time, and once it's there, it can be very, very hard to reverse. And we've also seen the flow-on effects of that, an inability to be able to increase the eccentric hamstring strength in those with a history of injury, and persistently poor structural characteristics as well, in the shape of fascicle lengths. So to kick things off in terms of some of the data that we've collected in recent times, I want to talk about strength and structure, and particularly architectural characteristics, and what that might mean in terms of risk of injury. The quickest way we can do, and to summarise that, is to talk about what we've come to term the hamstring quadrant of doom. Now, this is data that we've taken as part of Ryan's PhD in a prospective cohort study in our elite soccer competition back home in Australia. So at the start of their pre-season, measured Nordic strength, and then also assessed biceps femoris fascicle length as well. Obviously then looked to see who remained hamstring injury free and who didn't. And based off that, we were able to divide the group into short or long fascicle lengths, and then high or low levels of strength. And if you imagine that we can break those up into 4 separate quadrants. Then we look at the distribution of those who remain injury-free throughout the pre-season and in-season period. What we see is there's a relatively random scattering across the X and the Y axes there. And when we overlay those who then went on to sustain an injury, what we can see here is there's a strong concentration of those that go on to sustain a hamstring injury in that bottom left quadrant. So in terms of percentage, 40% of those who fell in that quadrant of doom went on to sustain a hamstring strain injury in the pre-season or the competitive season, compared to one unlucky fella here in that strong and long group who goes on to sustain an injury. So from our perspective, we obviously know that hamstring strain injuries are multifactorial, and there's so many different things that interact and so many interrelationships, but this is just for us a nice visual example of how combining different elements of data can actually show you, I think, some really interesting things. Now, we've got a heap of these graphs, and I won't show you too many, but just one today, which shows the interrelationship between modifiable and non-modifiable risk factors and what that means in terms of probability of future hamstring strain injury. So on this graph, we have the probability of hamstring strain injury here on the left. So no chance that they'll sustain an injury through pre-season or in-season. And then up here at the top, it's certain that they're going to sustain an injury. Now, on this graph, it's modelled against biceps femoris fascicle length, but we've done the same thing for eccentric strength, and the same relationship persists as well. What you can see here is that the individuals who entered that season with a hamstring injury from the previous season are always at a greater probability, have greater risk of injury compared to those who didn't have a hamstring injury in the previous season. But notice that those groups become remarkably similar when we look at longer and longer levels and lengths of biceps femoris fascicles. The big discrepancy between those groups is when those with a history of injury also possess a poor modifiable risk factor as well. So for us, it's really been the line of thinking that we need to appreciate, acknowledge and understand those non-modifiable factors. But what are the factors outside of those non-modifiable ones that we might be able to modulate and manipulate to offset that level of risk? So I think that's a very brief snapshot and synopsis of some of our prospective work. I think generally speaking across the hamstring injury literature, it's fair to say that increasing levels of eccentric strength, whether that's measured directly or whether that's through interventions with the aim of increasing eccentric strength through the use of, say, the Nordic hamstring exercise, I think has got to be a primary component of any program that aims to mitigate the risk of future hamstring strain injury. For the sake of today, I don't want to spend too much time talking about strength adaptation because I think there's probably far less known about the adaptation of structure, and in particular the best ways we can modulate and manipulate biceps femoris fascicle length. So throughout the course of 3 or 4 studies, we've tried to answer what we think are relevant questions from an adaptation perspective to help drive decision making from a clinical perspective, considering the importance we've seen in fascicle length. The first one was whether contraction mode was important. Now again, this is a 6-week intervention study from Ryan's PhD. That's the end of the intervention there. There was also then a 4-week detraining period here. So across that entire 10-week period, these individuals were continuing their normal habitual levels of physical activity, recreational level athletes and some sub-elite athletes. Throughout that 6-week period, they had exposure to strength training on an isokinetic dynamometer, either concentric or eccentric strength training only. And then at the end of that 6-week period, 10 weeks where we removed the strength training stimulus and they just continue their habitual levels of activity. Both groups starting at roughly the same point, and that's the effect of concentric only training on biceps femoris architecture and fascicle length. Note how quickly the adaptations can occur. So there's significant changes there occurring within 2 weeks that ultimately persist through the end of the intervention at the 6-week period. The interesting thing from a concentric training perspective is that with the removal of that strength training stimulus, that adaptation has ultimately become the new norm. Shortened fascicles have then persisted and maintained even after the strength training stimulus has been removed. Now, if we contrast that to the eccentric training group, almost the exact opposite effect within that first 2-week period. And again, that adaptation persists across a 6-week window. But the important thing for us is that within 4 weeks, all of that adaptation that's occurred across that 6-week period is essentially gone. So that eccentric adaptation that we perceive to be favourable is gone as soon as that stimulus is removed. Now I'll show you in a few slides' time some shorter windows for that detraining effect, but it is incredibly rapid, and I think to me signifies the importance of continual application of an eccentric strength training stimulus to maintain favourable hamstring adaptations. The next question, and it's always a question that we get asked, and we don't necessarily have the right answer to it because I don't think there is the right answer, but what is the best exercise for hamstring injury prevention or hamstring injury risk mitigation? And of course, that's an impossible question to answer. What we need to, I think, move towards is understanding the pros and cons and the strengths and weaknesses of all the exercises that we use for hamstring conditioning to try to drive positive adaptation, and then understand how we can manipulate those exercises throughout a training program. The first step we had at looking at whether exercise selection was important was to compare the Nordic to this hip extension or back extension exercise here on a Roman chair. Now, we deliberately selected these two exercises because an earlier study showed that they had differing activation profiles when we were using EMG. So acutely, the Nordic had a greater tendency to activate semitendinosus, or the medial hamstrings, compared to biceps femoris, and the hip extension seemed to be more lateral dominant. Okay, now that's when we're looking at ratios of EMG, and I think that can be somewhat misleading at times as well. But considering that the EMG said that that was more of a medial dominant exercise, and this was more laterally dominant, we thought an examination of those two exercises would be quite important. We also thought it was interesting that one of the criticisms of the Nordic is that you're not exposed to long enough muscle tendon unit lengths for it to be relevant for hamstring injury prevention or risk mitigation. Ultimately, we think the exercise is really useful because there's a supramaximal eccentric strength training stimulus, and that probably to some extent overcomes the limitations in the range of motion. So eccentric only exercise, knee dominant, short to moderate length, hip dominant exercise, concentric and eccentric phase, and obviously larger muscle tendon unit maximum range. So in this study, 10-week intervention, no detraining period in this one, but what you can see here again, 2 training groups and a control group, and that first group that we see there is the effects of 10 weeks of Nordic training on biceps femoris architecture and adaptation. Interesting to note, the hip extension changes across 10 weeks from a statistical viewpoint, from a p-value perspective, are no different. But when we have a look at the effect between these two, this is a moderate to large effect between those. So to my mind, it suggests that 10 weeks of Nordic training actually resulted in greater adaptation at the architectural and fascicle length level. And just in case we were concerned about all of us sitting around doing nothing, punching away on the keyboard, if we do absolutely nothing, we get absolutely no response. I think the last of a series of studies that we're doing at the moment, and we'll continue on with the exercise selection work, but is to also look at the dosage of the Nordic hamstring exercise. And it's particularly pertinent for us considering the paper by Jan Ekstrand, Roald Barr and Christian Thorberg that talks about the randomised control trial protocol by Jesper Peterson, which has shown that Nordics are effective for minimising the risk of first-time and recurrent hamstring strain injuries, but that program is not adopted at the elite level. And one of the reasons for that is purportedly that the training volumes are just not feasible in an elite environment. Having to do the exercise 3 times a week, 8, 10, 12 reps per session is just not something that they're able to do. So what we wanted to look at was to see whether exposure to high or low volumes had any impact on the adaptation. Note here that our high and low volume groups are actually identical during the first 2 weeks. So both groups there are training twice a week. But then after that, there's a 4-week period where the volumes diverge quite largely. The high volume group continues to train twice a week, but ever increasing volumes. And the low volume group training once a week with 2 sets of 4. And that's the upshot of it. So the effect of high versus low volume training across that 6-week period was not different at all. Now, again, you'll notice some pretty rapid increases within the first 2 weeks. So perhaps we may have masked the effect of volume by having this standardised period here, but we wanted to make sure that the 2 groups adapted to a similar extent during or with that exposure. But you can see here, past that point, almost a maintenance dose here, 1 session a week, 2x4, was enough to maintain all the benefits and gains that you got from that, what we might say is a big bump in the first 2 weeks. I think the other important thing to notice here is we've looked now at shorter detraining windows now, and this mid-detraining period here is after 2 weeks. So just like we see adaptation occurring, positive adaptation occurring within a 2-week period, that detraining effect, removal of that stimulus within a 2-week period basically negates all the work that's been done across that time frame. Again, for us, the importance of not missing eccentric loading stimuli and making it a consistent part of your program. Now, I didn't speak about this much at all through all these interventions. We're concurrently taking measures of strength, and I think one thing that's been particularly interesting for us to notice is that when things are going good, when we're seeing positive adaptation, increases in fascicle length, that tends to be mirrored by increases in eccentric strength as well. But across 3 studies now, 3 studies where we have detraining periods and we look at architectural changes in detraining, we look at strength training in strength maintenance in detraining, what we see is that there's very, very little effect on that detraining period on eccentric strength. So the mechanism for maintaining strength appears to be very different to the mechanisms for being able to maintain those architectural adaptations as well. And obviously if we think about strength, there's not only structural characteristics, but there's neural characteristics as well. But I think be mindful and cognizant of the fact that if you do remove eccentric strength training, you can still maintain a level of eccentric strength, but that doesn't mean that you necessarily still avoiding some of the bad things that might come away from that as well. Okay, the last thing I'd like to talk about today, at least from a data collection and study perspective, is the work that we're starting to do now in the rehab space. And it brings us to some extent full circle, because we started looking at this issue of inhibition, but in individuals who had already been rehabilitated and returned to play, and we had no control over that. So we thought that, well, rehab probably presents the perfect window of opportunity to be able to short circuit that loop of inhibition. If we're able to, and in our mind, be a little bit more aggressive during rehabilitation, there's perhaps that we can short circuit that time course or path of inhibition, ultimately then cutting out some of these deficits here that we see in our previously injured athletes. Again, still with the aim to return quickly and to try and keep that risk of re-injury as low as possible. So I'll thank Jack Hickey, PhD student of mine in Melbourne, who's put these slides together for a conference in Australia a few weeks ago. To Jack's eye, this is an amalgamation of the conventional guidelines for hamstring strain injury rehabilitation. taken from a number of different sources, and it's not a complete representation of all of them, but we think it probably represents the body of evidence here as best we possibly can. Typically, 3 stages, where rehabilitation in the early phases tends to be some low load isometric contractions, increasing in intensity at varying lengths. Need then to pass predetermined progression criteria to then move into the next phase where we start to get a little bit more aggressive with our loading, start to increase some of the lengthening demands with dynamic contraction. Again, a gateway to move our way from 2 then through to 3, where we then start to look at what we think are some of the more aggressive options that we have in rehabilitation. Now, from our perspective, our alternative guidelines probably de-evolve these stages of rehab and then also these progression criteria. So the aim really for our rehabilitation is to expose individuals to all of these stimuli on the first day of rehabilitation and to progress or regress those through rehabilitation based on how the athlete responds. So to give you a quick snapshot of our concentric eccentric model at length, very typical hamstring bridge, our concentric eccentric long muscle length, the hip extension exercise that you saw earlier, and then we start off with the sub-maximal eccentric exercise, and I think we've come to term it a hamstring slider, but I think we stole it from someone else, I just can't remember who. This is basically just bringing your heels in towards your backside, hips up off the bench, and then slow and controlled knee extension. So bilaterally in the first pass, difficult, but not all that difficult. So as I say, those 3 exercises are all introduced within the first rehabilitation session. First time we see them, clinical exam, and they're exposed to each of those exercises. The progression for each of those is based on how they respond in rehab. So part of Jack's RCT is actually looking at whether pain-free full range of motion is actually necessary for progression, but that's a story for another day. But you can see here, shifting to a unilateral variation. Same here with the back extension as a means to increase intensity. And then for that bilateral slider, then working to a unilateral slider. Now, I think this is one of the major innovations out of Jack's work, because being able to pass that bilateral slider is actually our gateway to then progressing into the Nordic hamstring exercise as well. So we look at this as being a sub-maximal but joint-specific and contraction mode-specific introduction to Nordics. If they can handle that, we've said, all right, we're going to throw them in the deep end and see how we go. And we held our breath a few times, but I'll show you some of the data that we have from that. It's worth noting that we don't disregard the isometric contractions, but we tend to use it more as part of our clinical exam. So we have an instrumented setup, and as part of everyone's clinical exam when they come in for every session, is we're taking force time data and then looking at rate of force development and also peak knee flexor strength as well. So that's how our flow works, and if you think about bringing that back to how we see the conventional guidelines, you can see that you have the risk and run the risk here of running into a real bottleneck. If you're waiting to progress through exercises by waiting for pain to resolve during isometric contraction, then conceivably you're restricting people's ability to progress to these more heavily loaded exercise, more aggressive exercises until this is resolved. So to give you just a bit of a snapshot of some of the data that's ongoing, we're probably about halfway through this RCT, but using our alternative guidelines, when we've introduced our long length, and let's focus on the eccentric only exercise here, the Nordics, on average in our group, they've been introduced to their first exposure to Nordics 4 days post-injury. If we compare and contrast that to if we had waited until they were pain-free on their isometric contractions to introduce eccentric loading and eccentric only loading, we would have waited roughly another 7 days. Now you might look at that in the grand scheme of things and say that's only an extra week. But if you think about the typical length of rehabilitation and return to play, particularly in elite sport, and considering that we see our participants, our patients, 2 to 3 times per week, that's perhaps the difference between 2 to 3 additional loading sessions. Now, it's worth noting here that this is not necessarily a return to play time. This is when we discharge them from rehabilitation. Their return to competition is probably about 7 days after that. So they leave us, they go back and have a full week of full training, and then they typically return to play from there. But I think it's worth noting that that probably tells us that we're looking at high grade 1s to low grade 2s in terms of this population here. just probably to further support some of that, I'd like to present to you 3 case studies. So this is data from their initial clinical exam, either a day or 2 after they sustained their injury. The 3 measures here you see are part of our clinical exam, a lot of it derived off the rehab work that's done here. So from those 3 participants, okay, pain on palpation, that's not unexpected. Okay, some increasing levels of pain with active knee extension as well. And then again, across the board there, increasing pain on their isometric 90/90 test. So as per the conventional guidelines as we read them, this would really hinder and halt their progression through hamstring strain injury rehab as we've defined it. But the interesting thing to note is that despite this pain here, all 3 of these guys were able to complete that bilateral slider in the absence of pain. And so as per our progression, they launched on into the Nordic hamstring exercise. So these 3 participants, which are reflective of the cohort at large, 1 day or 2 days post-injury were doing the Nordic hamstring exercise as part of their rehabilitation. Now, I think as playing devil's advocate, you might look at that and say, well, the Nordic is an exercise where you can conceivably just fall through the entire range of motion. You can say you've done the exercise, but you haven't really. So if we have a look at the outputs for isometric strength from that clinical exam, looking just at the injured limb there, again, we can see somewhere between 100 to 200 newtons across those 3 people. And if we have a look at their output then on the Nordic, on average, in the vicinity of 100 newtons extra in the Nordic hamstring exercise in terms of the force that they're exerting. Okay. Of course, the Nordic can be done bilaterally or is done bilaterally, so you could also make the argument that that injured leg is doing less of the work and far more of the work is being done by the healthy leg. So if we have a look at between limb asymmetry here, again the isometric measures as we expect, the injured leg is down to some extent, quite significantly. And if we compare and contrast that to the Nordic group, you can see that their asymmetry is actually within a 10% sort of arbitrary cut point. So for us, I think that's evidence to us to say that they are exerting relatively forcefully, they are doing it relatively evenly on both legs, and a day or 2 after injury, they're doing it in the absence of pain. And we have no idea what the mechanism for that is, how that comes about, but I think it is an important consideration that we need to think about contraction mode specific progressions through our hamstring rehab programs. So it's probably all well and good to suggest that we can be, well, we're aiming to be a little bit more aggressive throughout rehab, but what are some of the benefits of that? I'll bring you back to that quadrant of doom slide from earlier. Again, strength and architecture just cut at the exact same time points as before, or beg your pardon, cut points as before. That's where those 3 individuals started on day 1 and day 2 post-rehab. And if we have a look then at 12, 14 and 17 days post-rehabilitation, that's the progression that all of those individuals have made. And to me, the most extraordinary one is here, with participant C, working all the way from that short and weak quadrant very, very quickly then into that long and strong quadrant. So I think from our perspective, some emerging work to suggest that there's some scope for this to be looked at further, and hopefully we can expose a little bit more of that as part of our RCT. I just wanted to really briefly finish off to explain probably the reason why we're here, and it's some of the plans that we have for the future. So myself and Ryan, in conjunction with Rod and also Imad Al-Musa from radiology, were fortunate enough earlier this year to have a successful QNRF program grant funded for 3 years. And it's a 3-phase project, and it focuses very much on the architectural work that we've been doing, but the first phase of it is to try and identify some MRI sequences that might be able to give us tracking of fibres and lengths of fibres, not only in biceps femoris but across all the hamstring muscles, and indeed over time across all the muscles of the lower limb as well. So that study, or this DTI technique here, which is more commonly used to track cortical pathways, as you can see here, a nice colourful representation here, can actually also be used to give us an indication of fibre tracks and fibre lengths across the length of the muscle. Obviously the ultrasound techniques are always very much operator dependent, so the ability to validate some MRI techniques for that I think is really exciting. The follow-on from that will then be to use both of those methods to extend a little bit the dose response work. What you can see here in group 4 is the first 6 weeks of the Peterson protocol, and then the other 3 here, which are our sort of experimental groups, looking to see whether actually you can get away with an exposure only once every fortnight and whether you'll still be able to maintain or engender really strong adaptations from that perspective. And then I think finally, and I think most excitingly across the board, is the ability to be able to embed those measures into the rehabilitation program here at Aspetar. So the ability to have ultrasound measures of architecture embedded throughout rehabilitation, to be able to look more at the time course of that adaptation and how manipulations and modulations of a rehab program might be able to influence those architectural characteristics. But then also at the end of rehab to take the ultrasound and the MRI measures to determine whether any of those architectural characteristics are actually important from a re-injury perspective as well. And I think presents a fantastic opportunity for anyone in this region who's able to get access to these technologies, those skills. I think it's going to be some really important and exciting research moving forward. That's it from me. I'd just like to perhaps finish by saying, I'm here presenting the work and the hard work of a lot of other people, not just myself. We're incredibly fortunate just to have a really good group of people who are all interested in the same stuff, enjoy working together and enjoy the work that we do. So it's a pleasure and an honour for me to present not only to you guys but on behalf of the extended team that we have. Thank you.